Hello, my name is Julianne Justo, and today I'll be reviewing pertinent drug information for SARS-CoV-2 as it relates to ribavirin. The mechanism of action of ribavirin is rather interesting. It's a guanosine analog that's phosphorylated inside the cell by adenosine kinase, and this results in metabolites of ribavirin monophosphate, diphosphate, and triphosphate. These metabolites can then go on to have both direct and indirect actions inside the cell. So direct actions regard inhibition of RNA polymerase, which results in chain termination, inhibition of RNA capping activity for the virus, as well as lethal mutagenesis of the viral RNA genome. Indirect mechanisms of action include inhibition of inosine monophosphate dehydrogenase, or IMPDH, which lead to a depletion of guanosine triphosphate, or GTP, inside the cell. It also seems to have an immunomodulatory effect and enhances T-cell mediated immunity in favor of T helper type 1 cytokine profiles, which can help combat certain viral infections. Overall, this leads to a mechanism of action where ribavirin is known for having relatively broad spectrum antiviral activity. Here you can see the different dosage forms of ribavirin available on the United States market currently. The majority of these come in oral form, tablets, capsules, or solution, but then you also have an inhaled solution as well. Dosing for ribavirin most commonly is going to be done for either chronic hepatitis C infection or respiratory syncytial virus infection. And what you'll notice here with the wide variety of either weight-based dosing that we do for chronic hep C in combination with things like direct acting antivirals, or for respiratory syncytial virus, which is often done on its own, you can see that the adult daily dose is somewhere between 1,000 to 1,200 milligrams. It's a little bit higher for RSV at about 1,200 to 2,400 milligrams as an oral component. Now, the inhaled, which happens to be much more expensive in the United States than the oral, is available at much higher doses of 6,000 milligrams inhaled as a total daily dose given over 18 hours or broken up into 3 administrations over 2 to 3 hours 3 times a day. Now, it's important to kind of keep the oral adult daily dosing in mind because that will be how we relate it to some of the other dosage regimens that have been used for coronaviruses in particular. So looking specifically at severe acute respiratory syndrome, or SARS, and Middle East respiratory syndrome, or MERS, in these particular cohorts of the studies that have been published, usually the ribavirin was given orally, sometimes it was given IV. Frequently, it was in combination. With SARS, it was in combination with corticosteroids, and MERS, it was usually in combination with either interferon or lopinavir and ritonavir. And what you'll notice for SARS is that very high doses, equating to about 8,000 milligrams orally of ribavirin, were typically given, or high doses at about 3,600 milligrams by mouth were given. You'll also see the kind of detailed dosage regimens that come from the published studies and the calculation of going between an IV formulation for the quote-unquote very high dose to an oral equivalent was based on an oral bioavailability of about 50%. Now, it does range for oral ribavirin anywhere from 33 to 64%, but I chose 50% just for the sake of the calculation. The point is the IV regimens that we gave for SARS were much, much higher overall amounts of ribavirin than what we typically use for hepatitis C or RSV. For MERS, it seems like the total adult daily dose used in those studies was still high, but a little bit less. And so it was on par with what we would call high dose for SARS at 1,800 to 3,600 milligrams orally. So overall, what I wanted to demonstrate was that the oral doses for ribavirin were relatively much higher for coronaviruses that we've attempted to treat in the past. Keep this in mind when I ultimately show you the in vivo data for these particular viruses in a second. That leads us to the current ribavirin dosing that's being employed for severe acute respiratory syndrome coronavirus 2, better known as SARS-CoV-2, either in combination with interferon alpha or lopinavir ritonavir. So we're still giving relatively high doses, what would be the oral ribavirin equivalents of about 2,000 to 3,000 milligrams of ribavirin orally per day for an adult. And the dosage regimen that's listed here comes from the 7th edition of the guidelines for COVID-19 pneumonia, published by the People's Republic of China. And so they're employing ribavirin 500 milligrams IV every 8 to 12 hours for up to 10 days, again, in combination with those other antiviral agents. Unfortunately, we don't have good clinical data yet that's been reported as to how these particular regimens are doing, either from an efficacy or a safety perspective. In vitro data for ribavirin with SARS-CoV-1 is rather interesting. Ribavirin appears to inhibit SARS-CoV-1 replication at either 50 or 500 to 5,000 micrograms per ml. And this seems to be rather similar to the same amount of exposure in the body that would relate to cytotoxic effects of ribavirin, which was measured at 200 to 1,000 mics per ml. These exposure levels that inhibit SARS-CoV-1 are also much higher than the systemic exposures that we get in the body. Usually with an oral 600 milligram dose of ribavirin, the peak concentration in the plasma is about 1 to 3 micrograms per ml. So you can see we're pretty far way off from where the in vitro data suggests we need to be. For MERS coronavirus, the ribavirin half maximal inhibitory concentration was on par with what we saw for at least one of the studies with SARS-CoV-1 at 41.5 microgram per ml. But there was some signal of hope because the potency of ribavirin improved in combination with interferon alpha 2b. Looking at the in vitro data that's available for SARS-CoV-2, the ribavirin half maximal effective concentration, or EC50, was measured most recently a few weeks ago in a study that was published by Wang and colleagues at 109.5 micromolar. And this, in comparison to some other potentially promising agents for SARS-CoV-2, appeared to be about 100-fold less potent than the similar EC50s for remdesivir and chloroquine, which were around 1 micromolar in comparison. The half cytotoxic concentration for ribavirin specifically was listed at greater than 400 micromolar, and that combined resulted in a calculated selectivity index of greater than 3.65. So that's not a very wide therapeutic index for the antiviral agent of ribavirin, specifically for SARS-CoV-2. Animal data is somewhat mixed. The first study is looking at ribavirin monotherapy in a lung infection mouse model of SARS-CoV-1, and it was shown that ribavirin may contribute to the pathogenesis of SARS-CoV-1, which is unfortunate. And that was demonstrated by higher virus lung titers, higher time that the virus was detected in the lungs, and higher pro-inflammatory cytokines with ribavirin-treated mice compared to placebo-treated mice. In contrast, when ribavirin was put in combination with interferon alpha 2b in a rhesus macaque model of MERS infection, it seemed to improve outcomes. And here that was demonstrated in the rhesus macaques by decreased breathing abnormalities, improved radiographic findings, and decreased pro-inflammatory markers in the animals that were treated with ribavirin and interferon compared to placebo. Looking at select in vivo data for ribavirin, particularly as it relates to SARS-CoV-1, I've tried to outline, there's a lot of data that we could go through, and unfortunately we don't have the time in this brief presentation. So what I've done is just listed what I thought were representative trials of what the ribavirin data look like. The first two trials were published in 2003 and 2004. They were both cohort studies, and they both looked at a combination of what was essentially lopinavir/ritonavir plus ribavirin plus steroids compared to controls that just received ribavirin and steroids. Now, these studies are both broken down in further detail in other videos, but for the sake of this video, we're focusing on what we can glean from this in vivo data as it relates to ribavirin. And unfortunately, what we notice is, particularly if you looked at the clinical outcomes reported in the arms of ribavirin and steroids alone, each of these studies posted relatively poor clinical outcomes with 14 to 15% mortality, 11 to 18% of patients requiring intubation, and in the second study, about 29% of patients experiencing acute respiratory distress syndrome or death. And this was different than when you had lopinavir/ritonavir in addition up front. Those arms seemed to do better. The last study of Chow and colleagues from 2005 was looking at instituting ribavirin monotherapy. And if patients didn't improve by 2 days, then they would start steroids. And that was compared to just supportive care at baseline. And then they would add the steroids at 2 days, again, if the patient didn't improve. 93% of the patients that were started on ribavirin had persistent or progressive symptoms at day 2. And then in addition, there were significant adverse drug events noted with ribavirin, posting numbers such as 73% noted anemia, 39% of patients with noted hypoxemia, which at least numerically were higher than the drug arm without the ribavirin. These are lower quality data. These are smaller numbers. There's issues with the trial design in this case, but at least descriptively, we're certainly not getting any signals that ribavirin will be a panacea for SARS-CoV-1. And this data was summarized very nicely in a 2006 systematic review that looked at 30 trials evaluating ribavirin for SARS-CoV-1. 26% of them were deemed inconclusive in terms of the efficacy for ribavirin, and that's mostly because ribavirin was given in combination with lopinavir, ritonavir, or interferon, making it such that it was difficult or impossible to distinguish the treatment effect of ribavirin itself. 4 of the studies actually demonstrated possible harm, and this was noted with, as an example, hemolytic anemia that ranged anywhere from 36% to 61% in these trials. So again, not looking very promising when taken in totality for the in vivo data for SARS-CoV-1. Switching gears to MERS, I've provided 2 select trials, one that was treatment of MERS and one that was post-exposure prophylaxis in MERS. The treatment study, Arabi and colleagues, was published in 2019, and that compared ribavirin and interferon, again, in combination, versus no antiviral therapy. And it unfortunately posted relatively disappointing outcomes. There was no decrease in 90-day mortality and no faster viral clearance of MERS with the combination ribavirin therapy compared to no therapy at all. And the Park and colleagues study was a cohort study of healthcare workers with high-risk exposure to MERS coronavirus. And this one also looked at combination ribavirin, but this time it was lopinavir, ritonavir instead of interferon. That was the second agent as part of the regimen. So that combined made the post-exposure prophylaxis regimen, and that was compared to an arm of patients that did not have post-exposure prophylaxis. This study was actually somewhat promising insofar as the patients with PEP had a lower MERS coronavirus infection rate compared to those that did not have post-exposure prophylaxis. So 0% versus 28.6%, and that was significant. However, for the patients that received PEP, which included the ribavirin plus the lopinavir and ritonavir, we were still noting relatively high rates of things like anemia and leukopenia at about 40 to 45% in the group of patients that did receive post-exposure prophylaxis. So maybe there's some signal here. Unfortunately, it's unclear if the lopinavir or ritonavir was doing all the heavy lifting for prophylaxis for MERS itself. It's essentially impossible to distinguish. Shifting gears a little bit from the in vivo data and looking at the safety data for ribavirin, this agent is known to have 2 black box warnings, one for hemolytic anemia and one for teratogenicity. Therefore, significant caution should be applied to patients with a history of significant or unstable cardiac disease, and it should also be avoided in patients who are pregnant or in their male partners. Adverse drug events noted in the trials that have used similar dosages as what we're considering using for SARS-CoV-2. These are the numbers that have been posted for ribavirin in the literature when adverse drug events are reported. You'll see that anemia kind of tops the list, ranging anywhere from 50 to 73%. And this anemia is interesting because remember with ribavirin, it has 2 main mechanisms. The first is hemolysis. As you have ribavirin triphosphate accumulating inside the erythrocyte, which it doesn't have a mechanism to get that RTP out of the cell, that results in intracellular ATP depletion and oxidative membrane damage. All of this leads to accelerated extravascular hemolysis of the red blood cell. and that can result in anemia. A second mechanism of anemia is direct bone marrow suppression at the point of generation of these red blood cells. This typically occurs with high doses of ribavirin, which include the doses being considered for SARS-CoV-2, and this is typically via an inhibition of IMPDH, and essentially the ribavirin at high doses turns into chemotherapy. And so if you look at the particular details for anemia, what have been noted in the trials, hemolytic anemia happened anywhere from 36 to 82%, and significant drops of hemoglobin of greater than 2 grams per deciliter happened, and at least half of the patients reported in one study. Focusing a little bit more on the Chow and colleagues study that reported that significant hemoglobin drop in half of the patients, that drop was also itself associated with significantly increased risk of mortality in those patients in the study. So this is not a causal link directly for ribavirin by any means, but it's at least a signal that we need to consider the anemia itself can be harming our patients as it relates to outcomes in management of coronaviruses. Looking at the remainder of the adverse drug events reported for patients receiving ribavirin, you'll notice that decreases in calcium and magnesium stores were relatively high at about 50%. That can lead to things like bradycardia, and hepatotoxicity is also a noted adverse drug reaction with ribavirin, usually in the form of transaminitis. Drug interactions with ribavirin is contraindicated with didanosine as it increases didanosine exposure and risk of mitochondrial toxicity. You'll notice a similar theme for other major drug interactions with ribavirin. Other nucleoside reverse transcriptase inhibitors like zidovudine, abacavir, and stavudine are considered major drug interactions because the ribavirin either impacts the NRTI efficacy and or potentiates toxicity. Azathioprine also is an agent that we would avoid with ribavirin due to increased risk of myelotoxicity, and warfarin with ribavirin can result in fluctuations in INR. Clinical pearls, we've talked a lot about the total daily dose of particularly oral ribavirin, and usually for hepatitis C and RSV, those are given in 2 divided doses. However, if you're doing high dose like coronavirus, you usually give it in 3 divided doses. Hematologic effects are dose dependent and reversible, so we do suggest getting a baseline and daily complete blood cell count for patients that are started on ribavirin, and then you can consider dose reduction and or potentially discontinuation of the medication if the hematologic effects become relatively severe. Consider checking a baseline electrocardiogram or ECG for patients with cardiac instability, and continuous cardiac monitoring or telemetry for those same patients being started on ribavirin. And lastly, be sure to check your electrolytes, such as the form of a basic metabolic panel, with the addition of things like calcium and magnesium to make sure that you don't have hypocalcemia or hypomagnesemia developing. And then you also need to monitor renal function daily, and that's specifically for dosing of the ribavirin, because about 1/3 of ribavirin is eliminated via the renal route. And so if the patient has renal dysfunction, we would have to dose reduce the ribavirin appropriately. Here are 2 relevant clinical trials that are currently ongoing for ribavirin, specifically for COVID-19 patients. Both of these are being undertaken in China, and you'll notice that both of these have ribavirin in combination with either lopinavir, ritonavir, and or some form of interferon. And so this unfortunately means that the data we'll get from this will not necessarily answer the question of the component that ribavirin contributes to efficacy and safety for SARS-CoV-2. Interestingly, ribavirin was notably absent from the WHO's Global Solidarity trial of the 4 most promising treatments for COVID-19. And I would encourage you to read this article for more information if you're interested. So in summary, ribavirin dosing, particularly for SARS-CoV-2, is unclear. High dosing is being attempted and investigated internationally for SARS-CoV-2. In vitro, ribavirin appears to be less potent than other potential agents for SARS-CoV-2, and it likely has a narrow therapeutic range for coronaviruses in particular. Of the in vivo data available from prior coronaviruses, unfortunately, ribavirin is deemed to have minimal to no efficacy data to suggest benefit with incorporation of ribavirin into some regimen for SARS-CoV-2. And we do have potential safety concerns with this agent that we have to consider, most notably anemia, which we know is dose dependent, relatively common, and that anemia has been associated with poor outcomes for our patients. Electrolyte and cardiac abnormalities have also been described, and if this agent is used for our patients, it will require close laboratory and cardiac monitoring. So all this information taken together hopefully assists you in making the appropriate benefit to risk calculation when considering ribavirin as a potential component of an experimental treatment regimen for COVID-19. And here you can see my contact information. You're welcome to contact me if you have any questions related to the content of this presentation.